One. Good evening, Michael. How are you this evening?
Happy Thursday, David.
Thursday. We're recording a little late this evening for episode 3.
Season 2.
Season 2. Okay. The only way I can remember, because you gave away a little too much on the last podcast, the 0202. So that prompted me. So thank you. So we are going to get rolling here because we're an hour late starting. It's already dark outside. And I'm really excited to bring in this evening's guest. But we'll do a little drum roll before she joins us, and I'll let you do that introduction. But we've kind of made this a thing where we talk about what was pressing in the news from the week prior, and we're really on a roll. So almost as hot of a streak is in May, where we went 4 for 4 during the month of podcasts every week. We are 3 right now. I think we can keep this going. So I want to keep the in the news real quick. So I do have to ask you, because you are the VR AR expert in the news this week. Another rehab tech company called Mindmaze made the news for what reason, Mike? Fill us in.
Follow the money, David. Follow the money. There were, those. Mindmaze is a company out of Sweden. They've been around for a number of years now. I remember when I was doing my thesis in the VR for stroke rehab space. And this was one of the only companies really doing something clinically validated for stroke rehab using virtual reality. So they've been around. Again, I would say at this point, gosh, it's got to be. I'm dating myself now, but I mean it has to be 7-8 years. So they're out of Sweden and backed by actually a bit of Hollywood money, Leonardo DiCaprio, and they have their hands in a few different pies, but one of their products is a clinic setting VR headset for stroke rehab. So they immerse patients in a VR experience. And for those who might not have, seen or experienced VR, it's a goggle that you put on, and you're kind of put into this immersive world. And it's starting to really gain traction with evidence-based medicine. So there's a few companies like Applied VR who use VR for chronic pain. And I actually just talked to a girl at the wedding I was at last weekend, and she wrote her thesis on the use of virtual reality for pediatric anesthesia. So, I mean, it's widely used. So Mindmaze, again, they made the news because they raked in about 150 billion for Series D validation. So I think what they're trying to do is really expand market. They're pretty predominant in Europe, and so now they're trying to make their presence known here in the US of A.
Well, thank
our
you.
Home country.
Yeah. And I would say with that bit of extra cash in the bank, maybe someone like a Mindmaze might make a great show sponsor at some point. You never know. I'm just putting it out there. We're not,
you're not far off, Dave. And just to, touch on it, because, and I know we do have Carolyn in the waiting room, but I do think that this, VR has such a major potential to really make a change for stroke rehab. How when I was doing my research, you're really thinking about doing, and as a physical therapist, you have folks come into a very plush PT office where they have railings, they have a nice, knitted carpet, they have the comfort around them. And what VR could do is put them in a place that is going to make them uncomfortable, but then build that cognitive confidence really when they go out into the real world, whether it's, stepping up onto a bus to get to the grocery market, or anything really to kind of train that that confidence from a cognitive point of view that they won't get in a clinical setting. So
Yeah.
I really like the move. Hope it could scale. I don't know if you want to
I
add
agree.
anything to that before.
No, just,
Carolyn comes
I
in.
tell my patients that all the time. You freeze, you fall, or you fail. So if you can give them the ability to feel comforted that they can move with confidence, that's great you brought that up, because I didn't even think of that as a real big positive to that altered experience like that, or that VRAR. So let's jump right in. Do you want to let our guest in? You want to do a little I feel like we're welcoming back an old friend in a way, but I know she's also very busy, so I don't want to keep her out of the room any longer. So
so Carolyn Brown is our guest this week. Dr. Caroline Brown, actually. For those of you who might have been with us since the start of the pandemic, when we first launched the Next Step Forward program, Caroline Brown was I need to emphasize, Dr. Carolyn Brown was one of our inaugural guests who really helped us design the Next Step Forward program from a the exercise rehab and lifestyle change point of view. So she's been super busy in the past, at this point, 18 months or so. So we'll invite her, bring her into the room, and see what she's been up to. Now, I have to say, Carolyn has been getting a bit of help from a technology point of view from her students. So we'll give her a pass here. She has her video off. She has her video off. Or the show. Carolyn.
I hear her laughing a little bit.
Hello. How are you?
We're doing great.
We said we're welcoming back an old friend tonight, and it feels just like that.
Yeah. Happy to be back. Thank you for having me.
And I just have to add, because I don't know, Mike, if Caroline, I don't know if you remember this, but do you remember we were working on, Mike gave a little intro before you joined us here, and we talked a little bit about you really stepping up and helping us with the Next Step Forward program. And maybe a few weeks after that, you and I were doing a follow-up call, and we were talking about our passion and like how we passion for education. Do you remember we were on a phone call? Because I started laughing when I was thinking I had a long ride back from work today in the car, so I was looking forward to this. And do you remember me taking a phone call from a potato field and a pumpkin patch?
Yes, that's right.
I think we had about a total of maybe 25 minutes of quality time. And I think I was climbing over to the next field. And I think I was on top of a big, I hope I didn't squish the award-winning pumpkin, but I was helping, things during that time were crazy. And for my wife and I, it was our solace. It was our little getaway, a safety. We were just out in our friends' field lending a hand, and I don't know why that struck me as so funny, but you were so gracious to hang on while I got better reception. And I think, Mike, I don't even know if I ever shared that with you, but I think you had a late practice that night. You were still over in Ireland. And I said, well, we got the call and it was a little different. And I don't know how much Caroline actually heard, but anyway, long way of saying welcome to the show, old friend.
I don't think I've ever had a phone call with anyone in a potato field. I think that was quite impressive.
It was a first for me too.
You were multitasking. You know what? Meaningful occupations. That's all that matters. So
there you go.
That's what you're doing. Oh.
So Mike's gonna probably put you on the not so the hot seat. We want to get you caught up. I'm going to ask you one hot question, okay? And then I'm going to let Mike go right into a couple of the questions we want you to get us caught up. But Mike and I have been at Enable Us for a bit now. We've been working hard. We've grown the podcast. Do you remember? Do we have a show or a project mascot?
Mascot.
Tough question. Tough question. Tough question to start.
A mascot.
Little- Mike, do you want to give it? You want to
There
give a
was-
little hint?
Was there something behind you on the wall? Didn't you have something up on the wall?
Perhaps.
Maybe
Perhaps
not.
it's in every episode.
Yeah, it wasn't that wall you're behind, or what is it?
It's a little shaky. You can't really see it in the
It's a
background
little
there,
shaky.
David.
It's a little late.
Yeah.
I rushed. I didn't have time to work on the lighting, but our mascot is our seagull, Wilson.
Okay.
He remains
got
with,
it.
so a lot has changed in the 18 plus months or whenever now. It seems like it's going, we have to start counting by the years, but that has remained stable with us. That has been our vision to give flight to enabling more opportunities for stroke. And you're such a big part of that at the beginning. And we want you to share what you've been doing since then, because I'm totally impressed by what you've been doing and your passion. So that was my softball question. Mike's going to ask you the tough ones now. So there we go.
I knew there was something up on a wall.
You were there. Go ahead,
No,
Mike.
we've
Sorry.
all grown. We have all grown and learned quite a bit in the last year, for
We
sure.
have, for sure.
Absolutely. So I've given a bit of background, for, obviously where you've started to help us last year, but let's dive in, for the guests who don't know you and, they're saying, who is Dr. Carolyn Brown? Let's start by first the doctor bit. So what's your clinical background? Where are you practicing now? And just give a little background of yourself.
Okay, so I've been an occupational therapist for 27 years. About 4 years ago, I decided to go back and get my post-professional doctorate in occupational therapy. I did it because I was just interested in moving beyond those clinic walls and seeing what else is out there, in particular research. So I got my doctorate. I graduated last May from Quinnipiac University in Connecticut. And I've been, since then, I continue to work in my day job, which I work part-time at a rehab hospital in Connecticut, the Hospital for Special Care. I would say the majority of my patient caseload are stroke survivors or brain injury survivors. And then I also, with the help of wonderful students and a wonderful board of directors, created or am creating a nonprofit called Stroke OT Incorporated in Connecticut. In addition to that, I do teach at the Quinnipiac part-time once in a while. Did a lot of teaching this summer, taught anatomy. I don't know what I was thinking there. And but now I have research students with me, graduate group of 4 graduate research students with me, and we're getting ready to kick off a new study in it pertaining to telerehabilitation, telehealth, and stroke survivors. So that's what I've been up to. So
Busy woman, a busy
Yeah,
woman.
is that all? What do you do in your free time?
yeah. Well, it's funny. I had to feed the kids dinner and they're downstairs, and I said to them, girls, when it's 7:15, you need to go in the tub. So we shall see. If I see the light turn on
Okay.
behind me, it means they're doing their thing. If not, they're goofing around.
Amazing. Well, it's been a whirlwind of 18 months, and forever for a lot of people, and especially for the stroke survivor community. A lot of those who are listening today have kind of been in limbo over the last 18 months, in terms of getting access to rehab, trying to understand what is life going to be in a rehab, or kind of that norm that I was used to, whether it's going to a stroke survivor group or my normal PT, OT classes, or really just that day-to-day life. I'm curious, what have you been doing, and maybe touch on particularly the exercise group that you've put together and been running from a telehealth point of view. I guess, what have you learned from that, and what would you say to survivors out there listening who still might be looking for that extra motivation? And, is there anything that you could suggest, and open doors to those folks listening?
Right. So the exercise groups that I've been running via telehealth, they pretty much it was, let's see, pandemic started mid-March of 2020. I found myself furloughed from my day job. I found myself laid off from my teaching job. I was home, and I reached out by email to some folks that were in my in-person stroke exercise group at the hospital. And I said, I'd love to just keep going. Would you be interested in meeting on Zoom? So it started small, just with a few people. And it was, of course, at that time, assuming the pandemic was just going to last a few weeks. But it continued. So that telehealth group that I started on Tuesdays at 1 o'clock continues to this day. When the hospital reopened, of course, groups still weren't allowed in person at the hospital. So I said, well, I'm going to keep going on my own and via telehealth. And then finally, this past June, the hospital did allow in-person groups to start. And what I did is, instead of restarting my group, completely stopping the telehealth group and restarting my in-person group, I said to the hospital, listen, I'm kind of doing my own little thing right now, and it's working. I'm really enjoying these survivors getting together every week. It's addressing their socialization. It's addressing, kind of from a psychological standpoint, working out with other people is much more fun than working out by yourself. And then it's just a great way to just keep that motivation going towards recovery. So I said to the hospital, could you just give me space? I'm doing this on my own time. I'm not getting paid. Can I just have space at least? And the hospital graciously said yes. So what I've been doing since June, July of this year is that on Tuesdays, I have my telehealth group and my in-person group both running at the same time. Now, what made me pleasantly surprised is that I was so convinced that as soon as I started offering in person, everyone would close their computer and say, no interest in telehealth. I was so surprised how many people stayed via telehealth. Now, these were people who had limited transportation, so they couldn't get to the in-person group. These were people that kind of have limited caregiver support in the home, so they could figure things out themselves to open their computer, etc. So I think it's been such a nice surprise to see that my Tuesday group, which I've expanded now, it runs an hour and a half. So we run 3 groups in a row based on everyone's functional level. And I've been pleasantly surprised that I've had equal number of participants via our telehealth Zoom as I have in person. Sometimes there's even more on Zoom than I have in person. And I think really this pandemic kind of taught people that telehealth is doable. It works, especially if you have limited transportation. So I can't remember your initial question, but that was what made me pleasantly surprised as far as you had asked about.
I think you hit him, and I'm sorry, I'm smiling and shaking my head because I'm following that same trend with the patients that I follow. And we see the numbers nationally for other disciplines, and we see, when they do customer satisfaction surveys from whatever, clinical profession it is, the satisfaction is high. But when you put a face in an exact example, when you kind of in your brain said, this works for now, I'm enjoying it, my patients enjoy it, but when it goes the other way, what's going to happen? And it showed that there's this social emotional part that you hit directly on the head that does not get addressed. Like if I look back to the days that I was in the clinic, many of my patients will come in and they want to kind of veer off. If because if you're working one-on-one, they want to kind of have a little fun with the person working next to them. And the reimbursement model sometimes doesn't allow so much for that. So what you just described is such like, that's like, yes, yeah, capital with all capitals. So, amen. You like, that's probably one of the reasons why you're studying this, right? As well, right?
It is. There's a study that I read recently where it said it had to do with adherence to a home exercise program for stroke survivors. So they took a group of stroke survivors in this study, and these survivors were getting typical outpatient therapy. And they looked and they saw, okay, 89% of those survivors were given a home exercise program to do on their own, but less than 65% of them were doing the home exercise program on their own within 1 year after they were discharged. So it just tells you that, I mean, I don't know about you, but if I'm given a piece of paper with some home exercises on it, I'm going to get bored pretty quickly.
Mhm.
It's that group, just the group dynamics are really what keeps the momentum going.
Absolutely. The HEP sometimes, for those, it's referred to shorthand in clinical notes as home exercise program, but I look at it and I've heard other therapists describe hand them photocopies because,
Yeah.
it's not as engaging as what you described. So Mike, I'm sorry to get off. I know
No, and I think, yeah, it's actually kind of gravitated to a very interesting point that I want to bring up to the both
Go
of you.
ahead.
Caroline, I think you made some amazing points, and you hit on things such as group exercise is more fun and engaging. With telehealth, folks who had limited caregiver support in terms of being able to get to rehab, they were able to access it. You could run different classes based on their functional level, and ultimately, that this model works, right? So my question, and I guess this goes back to my days when I worked in an exercise facility, which targeted, we worked with some hospitals and we did, post rehab, exercise, but it wasn't that rehab setting particularly. It was more fitness and exercise based. So maybe to tee it up to the both of you, do you ever see stroke rehab, especially in the exercise form, kind of moving to a model where, we've always kind of been hesitant to say, we don't want to charge stroke survivors, right? And I don't think we do, but if there's value, if there's convenience, and there's results, ultimately, I think, there should be a model where, that if you're providing this service, whether it's discounted through employers, things like that, but there can be a commercial model out there that makes sense, because ultimately the reimbursement, whether it's through Medicaid, any type of insurance, is not working, and it's very limited, right? So for any stroke survivor to get that results, they need to put in the extra work. So do you see anything out there where, there'd be models where, survivors would be asked to say, hey, instead of going to Planet Fitness and paying $10 a month, why don't you join these, exercise groups where you have that peer-to-peer support, you have that accountability, and you have professionals giving you that exercise program. Do you see something like that working?
Yeah, I mean, I do. It's interesting that from the research I've done, I think the stroke OT exercise groups are the only model of this form in Connecticut. And it's definitely, obviously, it's meeting a need. Finding how to make it commercially viable is definitely a good challenge. I think we therapists have a lot of work to do to think outside the box of the standard traditional rehab setting model. And that's probably going to be, honestly, kind of the biggest hurdle. There are, I can think of Gaylord Hospital down in Wallingford. They have a fitness program with groups, but it's all run by a grant from the Christopher Reeve Foundation, and it's run by exercise fitness trainers. So it's not run by therapists. So this would really be it'd be a wonderful opportunity to definitely expand. I don't know why it hasn't been done before, Mike. You're right. So far, the research I've done, I haven't found much. I have seen this model in Australia, over in Europe, but for some reason it's just not happening yet in the US, and particularly in like group forms. Like you said, instead of joining the Planet Fitness, you would join this, this type of program. So I don't know. What are your thoughts, Dave? I don't know.
I'll just add, we still treat it, unfortunately, like it's an episode of care, and it's a short, like you mentioned, we got to kind of break that mindset. We look at other conditions. You look at the way programs that have run successfully around, for example, pre-diabetes management. You have someone that's known to be at risk, and we get into the whole behavior change component, reduce risk, and it makes absolute sense. With stroke, the closest thing that I have found is, and it's specific to just mainly around balance and fall prevention, is like following like the Otago model, where instead of a short episode of care, they're seeing a health professional, which might start in clinic, a PT or an OT, to work on a particular problem, in this case, to reduce fall risk. But then we're not saying goodbye at the end of the month. We're following them where the data has showed in significant fall risk reduction as high as 35 to 40%. And a lot of that still is over in New Zealand, but making its way here, and is following it for a year plus, and following it, what, like you described, Mike, providing the support, providing that framework for continued success, and just say, okay, it's not, there's still a lot of hurdles on the reimbursement, but the numbers are there that shows it works. It's tracking the outcomes, and in that model, with that success, I'll just add, was done with follow-up phone calls, just phone calls. And that, if you add the telehealth component and the engagement part in the small group classes, you reduce barriers even further, and you open up for that whole social emotional part too, to bring in more shared experiences. And the learning and the empowerment comes from hearing other survivors' stories, and having someone say, this is normal, what you're going through, so I think that there's a lot of work to be done, but I think in a lot of things, it's going to take people like yourself, leading the charge and saying, this works. Let's build on this. So
yeah,
that's my 2 cents.
It's definitely creating from scratch. I wish our reimbursement system doesn't quite get that stroke recovery happens for a lifetime. This is not going to be happening within 6 months like some other diagnostic codes do. So, but they have to look at it that way, and they still don't see it that way.
And I think it goes back to, we've talked previously, Caroline, around that model of, what I've always been told, it's follow the money, right? So when we look at stroke rehab, ultimately, what would an employer on their books, be looking to do? Obviously, get them into the workplace quicker, So I think it's things like you've mentioned before, being able to find those biomarkers, such as chronic fatigue or, your fall risk, like what are those key identifiers that you could track as a stroke survivor that, you're improving on, to ultimately get to a place where you could get back to work? Because I think that's the number one goal. If we're seeing strokes happen at a younger age, but also all the money going into stroke. I know we just talked about, a virtual reality rehab program that got $150 million in funding, but really a lot of the money goes into the acute phase of stroke. So pre-hospital, all right, how could we make sure that this patient gets TPA, gets the right treatment before, before they get in the door? Even, you see models in Australia where they have CT scans in ambulances now. And it's, that's where the money's going, which is brilliant. But ultimately, what is that doing? It's creating a survivor who's hopefully, in some cases, less disabled because they got that treatment earlier in their care cycle than a survivor who, when it was my mother, or, the people who we know, David, you guys are, it was pretty much a condition that said, all right, well, you're disabled for the rest of your life and you're not going back to work. So I think it's that change of mindset. And again, it's going to take a voice. And I think we are, some of the top folks, who are pushing this. So let's keep it moving. But
keep it moving.
yeah. And maybe to dig a bit deeper to backtrack, we were talking about, let's stay on the theme of group exercise and kind of that engagement, right? So we mentioned before, and a big part of our Next Step Forward program was about behavior change and that that lifestyle redesign. What do you think? And I know you mentioned something previously when we were catching up before the call, Caroline, about an OT-based coaching program through telehealth, right? So that it's that extra layer of support, right? So if you put someone in a group exercise class, but then you pair them with a coach, whether it's a health coach, which we'll dive into in a couple episodes. We have a guest lined up, but it's that pretty much that accountability factor. And as David and I we've framed it, it's like when you start a new job, you get paired with someone who's a senior leader, and it's ultimately that support system. How do you see that working in a OT setting, or just stroke rehab in general? That coaching support.
Right. From the OT practice model and in my scope of practice, our coaching for this type of population is considered occupational performance coaching. I'm going to show you the book. This is an Australian model that was brought to the United States. Occupational performance coaching is just that. It was actually created for pediatric school settings and then expanded via research into adult rehabilitation settings, in particular stroke survivors. So there's quite a few studies out there on occupational performance coaching for stroke survivors. And there's some recent studies on occupational performance coaching, individualized coaching for stroke survivors via telehealth. And it's shown that it obviously is effective. It's done via much conversation. It's done initially by performing what they call an occupational profile, getting an idea of what your clients' patterns of daily function is, what are their beliefs, what are their roles, what are their values, what are their goals, and from that, kind of helping them identify really what their goals are. If I have a goal that I want to just be able to make dinner for my family, that's my primary goal, that becomes our goal with our client. And we have weekly coaching sessions in which we meet with them, set many weekly short-term goals, help them kind of do an activity analysis to break down the activity and figure out ways to either compensate so they can do it more independently, or just strengthen, remediate so they can do it more independently, and work towards that goal. So that's oops. Hello?
We still see you.
Oh, okay, sorry. So that's for some reason my Norton antivirus decided to cover the screen. Sorry. So, but anyway, from an OT scope of practice, this would be sort of coaching from an OT realm. Obviously, there's so many different forms of coaching out there. There's, fitness coaching and health, coaching via nurse, coaching via physical therapist, by respiratory therapist, by an OT. We all have coaching kind of a different, how would you say it, a different model, but we're all getting at the same thing. So yeah, so I'm getting ready to apply for propose to do a study that does involve occupational performance coaching and telehealth. So it would just look at a group of stroke survivors and get an idea if you are combining occupational performance coaching once a week in a group format. So the group of stroke survivors are actually learning how to support each other for each of them to meet their goals. And then you're acting just as a facilitator each week. That would be weekly for 6 weeks, in addition to a group telehealth exercise program. So looking at how all these would work together and how they would impact fatigue, depression, function, and cognition. We're kind of looking at a big piece there by doing assessments and then comparing it to a placebo group. So ideally, it's that would be coaching as far as from an OT standpoint. But I could imagine if there became a commercially available telerehabilitation program where it could be interdisciplinary, I could imagine there being being more effective, because occupational performance coaching, we're just looking at the goals of specific occupations. It would be wonderful, obviously, if there was, a PT working on coaching and then a nurse working on coaching at the same time.
I can see that. Those handoffs working perfectly and all working towards that same plan of care. So that's exciting.
It's the same. Yeah, it's the same science though, right? It's the same science of behavior change. It's motivational interviewing, it's goal setting, accountability, and kind of that progressive goal accomplishment, like along the way, and tying in the group element. So I love that you're exploring that route. I think it's definitely an area that needs some clinical evidence. So, driving that change and being, a pioneer in this field is super important. And I think it's going to pay dividends to some of the survivors listening, and hopefully, those, not to say those to come, but, the population that, will ultimately be, survivors one day that need access to care. It's going to really change the way that rehab is delivered. I truly believe. So great to see you going down that road. And so when you move and you've been in this for a little while in this telehealth space, like, bring us back 15, 20 years ago, Carolyn. Did you ever imagine that you would have been in the tele rehab, exploring group coaching, and it? Are you happy that this has come to be? Like, what do you see, I guess, are the question that we'd like to kind of wrap things up with, now that you've been along the lines in a clinical setting, and we're here in 2021, where do you see, us moving in stroke rehab by 2030, 2035?
Oh, that's a good question. Absolutely. 15 years ago, never in my wildest dreams would I think that there would be telehealth groups. I do think occupational therapy, our profession, has done a huge disservice by not offering groups, because our scope of practice tells us to address psychosocial skills. So that's the psychological function and social skills. And how do you address those when you're meeting individually in person with with telehealth via group? This is about the only format. And of course, I am doing it outside of the typical model. I'm volunteering to do this. So I'm not getting reimbursed by any insurance in any way, but I just see incredible things. And I'm hoping that just continued research in this will show that it's evidence-based, that it's effective. And I feel like if there's more studies that are out there that look at telehealth groups that also look at coaching via telehealth, as well as continued individual rehabilitation, I just feel like it's just going to continue to grow. It's still surprisingly fairly new as far as the research out there, but it's going to happen. I think in 30, it's what you're talking about, Mike, and what you're dreaming of. It's going to happen. There is going to be a commercial model, I can imagine, where people have this support for the long term, and it's going to save money for insurance. It's going to save money in the end. It's just, unfortunately, it's got to get researched so much more, and to build that evidence. And then, of course,
We're relying on you for that. So continue with what you're doing, because I think it is because you've stepped back and saw that there's a different way of doing it. It's going to be people like you that are the change makers, because you know, and so Mike brought you back. So our show is meticulously unscripted, but this is a perfect segue. Mike brought you back 15 years. I'm going to say, if I bring you forward 5 years, because we know from the patient perspective, which you shared, they embrace this. How do colleagues and peers, because I know what that answer is in PT, how do your colleagues and peers, when they saw and observed and know what you're doing, are they open to change? What's their, can you share any of that? I don't want to get you in trouble, but I'm curious.
That's it can be touchy. It really, yeah. How should I say this? So it's mixed. There are colleagues that feel very strongly that their paper home exercise program handout is all that a survivor needs to be discharged from therapy. They're wave goodbye, and then they're probably going to get a referral back in a year. I think sometimes some clinicians have a little bit of, how should I say, if they, instead of just giving them an exercise program on paper and say, see you in another year, if they instead said, why don't you join this cohesive collaborative group where you can exercise weekly, you have a chance of preventing falls, you have a chance of continue reducing your hyperspasticity, you have a chance of continued reducing your depression and post-stroke fatigue. And then, but you might not come back to me in a year. I think that's what tends to be a little bit of the hold that some clinicians might have, like, wait a second, if this continues and I refer people to this wonderful long-term telehealth support system, is my job going to be here? Is it going to be viable? And I don't want to point fingers in any way, but the writing can be on the wall a little bit. Like I said, I have colleagues extremely supportive that are sending people left and right. And then I have other colleagues that I know I hand them my flyers, I tell, but they haven't sent one person my way. So
Yep.
That's my 2 cents.
No, thank you for sharing that. I know it's a touchy subject, but I've had similar conversations in my area. And it seems like, I think there can be absolutely a perfect balance, but it's going to take the data to support that. It's going to take people like you doing the hard work, the day to day, to understand how to make that work and to sell it, because it does work. So I know we really appreciate your time. I don't want to, I know Mike's probably like, yeah, David's going to keep asking questions. Mike,
Sorry.
I'm done. I'm done, Mike.
I can go on too.
Like shaking his head there.
Hey, no, it's always good to chat. It's always good to chat, guys.
Hey, so I have to just,
I think we might be going through a bad internet patch here.
Uh-oh. We still,
am I back?
yeah, you're back. Carolyn's still,
Yeah.
Carolyn's, we're
Yeah,
still
I'm
there.
still good.
Okay, we better wrap it up while we have you. Caroline, how can folks reach out to you? We'd like to give you a chance to we'll put whatever you'd like in the show notes, as we always do following our guests. But is there any best way for folks to reach you that you'd like them to know about?
Absolutely. So please first check out the website, strokeot.org. On the website, there is a link that will connect you to a registration page to register for the exercise groups. I do have to stay, because of licensure laws, I can only have people in my groups that are from Connecticut right now. So I'm not allowed to have people outside Connecticut at this point. However, on the website, there are a great deal of pre-recorded videos of all of the exercises that we do in our groups. So people outside of Connecticut could at least view that. We also have on that first page a link to putting your email, and we'll share our monthly newsletter with you. So strokeot.org would be the first place to look. You could also email me at carolyn.brownot@gmail.com. You could, and also on the website, we can, there's links to our YouTube channel videos, Instagram, Twitter, all of the other ones. I have to say, I have an amazing board of directors, and I had an amazing 2 first occupational therapy students. They have done, I would say, this group of wonderful people, Michael, have done incredible things to build the website, build the social media channels, add videos, because I'm kind of old, so I'm not tech savvy. I can lead my groups, but when it comes to anything being tech savvy, I defer to my wonderful board of directors that have a great deal of technological knowledge. So,
Perfect.
but long story short, strokeot.org.
Strokeot.org. We also will put the information you shared on the Next Step Forward program. I think it was the Let's Move where you came in and did a great session on getting started with exercise. That's timeless. That's going to stay evergreen. We'll put it in the show notes as well, because it's worth to look back and look forward to all the new great stuff you're also doing. So Mike, take us out, because I've I'm running out of air, and I know we're running over. So
all right. Well, for those who didn't listen to the Let's Get Moving episode on the Next Step Forward program, we did a breathing exercise. So I'm going to put you on the spot here, Caroline, but let's send people out with a 30-second breathing exercise, and we'll sign off from there.
Wow. Okay.
All right. So we're going to work on what's called a grounding strategy, and a grounding strategy helps relax our body. It kicks in our vagal nerve, which helps increase our serotonin levels, and that helps to reduce depression, reduce spasticity, and just overall sense of calm. So we're going to work on some deep breathing. I'd like you to do a nice slow deep breath into your nose and hold it for 3. And slowly exhale for 6 seconds. Inhale again for 3 seconds. Hold and slowly exhale. For 6 seconds. Excellent. Do you feel a little better already?
I'm going to continue that off camera. I've got my tea. I've got peace. The dog's not barking. I'm going with that.
There's
Carolyn.
many more things we can do. Progressive muscle relaxation, vagal nerve stimulation, many things. But that deep breathing, diaphragmatic breathing is one of them.
Strokeot.com, folks.
That's .org. Yep, very good.
.org.
That's okay.
It's been a pleasure. It's been a pleasure. Thank you.
Thank you, guys.
Great. Thank you.
Bye-bye.
Good night.